Good morning, my name is Ioana-Irina Rezuș, and my PhD topic is about the management of pancreatic cancer from diagnosis to treatment. I'm a radiology resident and a bilateral PhD student between Grigore Popa University of Medicine and Pharmacy in Iași, Romania, and CTM here at Semmelweis University. My vision is to achieve a better management for patients with pancreatic cancer, and for that, my mission is to assess new diagnosis treatments and implement them into healthcare. I have two ongoing projects. Both of them are systematic reviews and meta-analysis. And the first one is about the efficacy and safety of therapeutic procedures for chronic pain in patients with unresectable pancreatic adenocarcinoma. Pancreatic adenocarcinoma is currently the 6th leading cause of cancer-related death, and it is expected to become the 2nd by 2030. More than 80% are diagnosed with unresectable disease, and up to more than 2/3 of them have pain at the time of diagnosis. The available treatment is consisting of opioids, but it is still associated with inadequate pain relief in more than half of the patients. However, there have been emerging more interventional ways to address this pain, so our aim is to find the most efficient out of them. We raised the question which method is more effective and safer for pain management in patients with unresectable pancreatic cancer, with population being adult patients, interventions and comparators being any kind of pain management. Our primary outcomes were pain relief and quality of life, while our secondary outcomes were adverse event survival and analgesic drug use, and we decided to include only randomized controlled trials. Our hypothesis was that interventional methods can provide better chronic pain management. We performed our literature search in 5 major databases and ended up with almost 5,500 articles. In the end, we could include only 21 in our analysis. I'm going to show you some results of our main outcome, pain. We measured pain at baseline and at different time points. Pain was measured on the visual analog scale, which ranges from 0, meaning no pain, to 10, meaning the worst pain possible. And we divided our patients based on the treatment they had. Here you can see the values at baseline, and the 4 study groups were either types of celiac plexus neurolysis, guided endoscopically, or intraoperative or percutaneous, or high-intensity focused ultrasound, which were one-time interventions. The last group, consisting of opioids, meant a continuous daily intake of opioids during the period of the study. As we can see at baseline in all of the study groups, the pain ranged from around 5 to around 7, meaning a moderate to severe pain. When we look at the dynamics of pain in time at 4, 8, and 12 weeks, we can see that at first, at 4 weeks, the pain results significantly got lower in all of the study groups. However, there is no difference between the study groups. Then, at 8 and 12 weeks, these pain values start to slowly increase, but again, there is no difference between the study groups. We could say that at 12 weeks, the endoscopic neurolysis performs better than the other. However, if we look at the number of studies included, it's just 2 in this analysis, so we cannot draw a definite conclusion from it. We also investigated adverse events. And of course, we expected that the opioids would have gastroenterological side effects. But in terms of neurolysis types, we see that, for example, for cardiovascular events, the frequency of these side effects was higher in the percutaneous celiac plexus neurolysis group. However, it is important to mention that all of these cardiovascular events were defined to be transient and lasting maximum 3 days after the intervention, and there was no severe event reported. In conclusion, the minimal invasive procedures provide pain reduction with fewer associated adverse events, and from the types of neurolysis, the endoscopic ultrasound-guided one seems to perform better. It is important for practice that we consider these interventions more often and more important earlier in the patient management. And for research, it would be better to have more RCTs, but that compare directly 2 different kinds of intervention, not one intervention with standard of care, and also that compare one-time interventions to multiple repetitions. The strength of our study was the large number of procedures included and also the multiple time points checked. Also the fact that we managed to include only randomized controlled trials. However, the number was very low of the studies included and they all had high heterogeneity. And the main problem was that there is not a gold standard for pain and quality of life assessment. So the analysis was pretty hard. At this point, our manuscript is accepted at the Translational Gastroenterology and Hepatology Journal, and we're waiting for it to be published. The second topic is about the diagnostic performance of different imaging techniques in pancreatic cancer diagnosis. As mentioned before, pancreatic cancer has a very poor survival, and the only chance of cure is resection. If we look at the overall 5-year survival, it is very low, it is only 4.6%. However, if we investigate the tumors, only the tumors smaller than 2 centimeters, we see that the 5-year survival rate is 80%. To identify these tumors as early as possible, we usually use imagistic methods such as CT, MRI, or endoscopic ultrasound. So our aim is to find the best performing imaging technique for that. We raised the question, which imaging technique has the best diagnostic performance for pancreatic cancer detection and staging? The population were adult patients suspected of pancreatic cancer. The interventions were any type, the index tests were any type of radiological examination, with the reference test being a pathological examination. And our outcome was the performance of detection and staging. We hypothesized that one investigation provides better results compared to the other, and this would be firstly important clinically because we would see an increase in the survival if we detect these tumors faster, and for the policymaker it is important to decrease the number of unnecessary investigations. We wrote a search key that had 4 domains and ran it in 3 major databases. First, we had more than 21,000 articles, but in the end, we got only 38 full-text eligible articles. It is important to mention that we included only either randomized controlled trials or direct comparative trials, meaning that all of the patients included in one study had all the imaging techniques that were analyzed in that specific studies. I will show you some results about tumor detection and resectability concerning the main 3 imaging methods used. If we refer to pancreatic cancer detection, here we can see results for CT, endoscopic ultrasound, and MRI. We can see that in all of the cases, the sensitivity is pretty good, also the specificity. However, there is no significant difference among these types of imaging. However, when we search for resectability, it is interesting to see that CT and MRI have the same sensitivity. However, the specificity with MRI is significantly lower than with CT, which from my point of view was an interesting result. At this point, our second topic is in progress, and we just started drafting the manuscript with the methods section. In summary, I have 2 ongoing projects. The first, we are waiting for it to be published as soon as possible, and the second one is still under work, and we hope to submit it by this autumn. During these 2 years, I have participated at different conferences and international congresses presenting our results, and also I do my second part of the PhD home at the Advanced Experimental Medicine Laboratory, CHEMEX. Thank you for your attention, and I will end with one of my most inspiring quotes: "Don't wait for opportunity, create it."
Congratulations. So 2 comments and 1 question. 2 comments to the second background slide. So the cumulative 5-year survival is not that low currently, so it is higher, close to 10%, because it was 2006 from the data from 2006. Mm-hmm. And the second one, not the size is the most important, the N has a greater impact on the survival. So the N status has a greater impact. And the question is regarding this first project. You mentioned unresectable, but it is metastatic or locally advanced, or what is the definition of unresectable? And if you include both of this, so have you made some kind of stratification based on this?
So first, for the second commentary, I just wanted to say that we will also investigate lymph nodes and metastases and all of them, but we just presented these results. And for the question, so the definitions weren't very strict. They said either just unresectable, they said palliative care patients, and the way they reported these results were not very clear. I would say it's a mixture of everything, but we don't have subgrouping or anything like that because we didn't have the data, actually. They just said that patients that are at the last hope and they just have pain and they want to relieve this pain, but they don't have any other hope for treating the cancer.
Okay, thank you.
Congratulations. My question is, I have two questions. The first is there a difference between the imaging techniques, between the same imaging techniques from, I don't know, the 90s and today's, and could it influence the results? Yes,
definitely. So this is also in both, also for tumor detection and for resectability. So for example, for CT, as an inclusion criteria, we had multi-slice CT, but all of those CTs range from 4 slices to 256 slices. So there's a big difference. In terms of the protocol, they say pancreatic protocol, but of course the machines are getting better and better, and we didn't have an exclusion in time, like machines after 2000 or something like that. So there is a lot of heterogeneity. Also for MRI, some of the MRIs are with MRCP, some of them are with diffusion, some of not. The contrast agents also are different. So in one group, there are many differences. We will try to make subgroups for the CTs in terms of slices, but I think this is the only subgrouping we are able to do, because in the other groups, there are not enough studies to make subgroups.
Thank you for your answer. And my other question is, you said that the specificity was lower for the MRI, and what do you think, why is that?
Again, there can be more explanations. First of all, CT is very standardized. However, for MRI, the protocols we found in the studies were different. Again, is it or not with MRCP together? The thickness of the slices in MRI is 3 millimeters. For CT, it was 1 millimeter. So I think this also is important if you look for small tumors. The tumors in these studies were not that small, actually. They were around 3-4 centimeters. But I think it's, the main importance is that CT is more standardized. And the results in the MRI studies varied a lot.
You mean how they do the...
Yes.
Thank you.
I have a question regarding your first topic. If I understood well, that there was a very good response at 4th week regarding the modalities or the chosen techniques, and thereafter there was a worse response. Mm-hmm. Was it your result?
I believe this is... first of all, these patients were in a lot of pain and something was done to them, so the pain decreased. From what I read is that the effect of the neurolysis of the alcohol agent disappears in time, it washes out. So this could be one answer for the procedural part. Also for the opioids, patients get used to them. So in time, this pain can come back if they don't get higher doses. This is why we also mentioned that it would be interesting to check the possibility of repeating these interventions so that the effect stays the same without washing out.
But could it be in connection with the disease progression?
Also that, yes, so, because it invades more.
Okay, and my next question regarding your second topic, what is your recommended modality regarding the pancreatic cancer detection based on your results?
I think because we have just a part of the results ready and not all of them, I wouldn't be sure what to say from our results. I can see in practice that CT is, of course, more used, but also because of the availability issues. But this would be interesting after we also make the subgrouping on the types of machines, because we need to refer to the machines we use nowadays and which are more common. And also, for example, if we find 7 Tesla MRI is performing better where it's not available everywhere. So I couldn't recommend that.
Yes, Ioana. You're from Rezuș. Which Nobel laureate? Well, we had that, and I think you know
we had
the
just
answer.
one, so.
Tell me, these localized intervention by CT and endoscopic ultrasound. Can you explain a little what you do in these procedures, where you hit for, what you aim for when you treat for pain? And maybe you can say something, there are also different agents you can use for that. Some investigators use alcohol.
Yes.
The upside is it's permanent, the downside is you need anesthesia. Then you can also use local anesthetics, you can use opiates or something like that. Maybe you can elaborate a little on the different techniques for treating localized pain by either EUS, what's the target really, and by CT.
In our studies, I think all of them used alcohol, so no other agent was used. And it ranged, the only difference was the percentage of alcohol, but in most of them was more than 90%. I think just 1 or 2 studies have 50%. The aim is the celiac plexus. In the endoscopic guided procedure, you just enter endoscopically and orientate yourself from what I saw, because I don't perform this kind of intervention.
Have you seen it done?
No, I mean, I've seen it online, but I didn't see it in real life.
Because there's certain vascular structures where you have to look for, and then you go to the left and the right of them. But go to the endoscopy lab and let someone show you how to do it. It's not done that often because it's not that effective. Yeah.
I think in our city they perform it more intraoperatively, like by the surgeons and not the gastroenterologists. They started performing it, but not that often. So, being in the radiology department, I don't see them that much. From what I saw for the CT guided procedures, there are more approaches possible, either posterior, either anterior, and it depends a lot. The most used one is the posterior approach, but again, if the patient has some kind of back problems, or you can go anteriorly. Anteriorly, I saw it can also be done, I saw in articles, under ultrasound guidance, but I think I just found 1 or 2 studies about that. And then there's also an interdiscal approach, and it's all based on the patient's profile. But from what I could see, the posterior one is the most done and recorded with side effects and how to
the distance is much shorter if you do it from posterior than do it from anterior. Yes. Right. That was a very good question from the floor. Sensitivity and specificity changed with time because MRI as well as CT became much higher resolution over time. So that's more of a hint than for the article you're publishing. Maybe you have to stratify by period or by technical developments. So maybe you have to have a look, or at least discuss it, whether it's a 1.5 Tesla, it's a 3 Tesla, it's a 5 Tesla for MRI, what kind of contrast media they use, gadolinium or something else. And the same is true for the resolution of CT scans. You have an answer to that, or you just I plan to discuss it in
We plan to do the analysis. I checked the articles included here, and I know they are very different. I think we would be able to make 2 subgroups on CT, like less than 64 slices, more than 64 slices. But there are articles, for example, they say we use 3 machines, 8, 16, 64 slices, but they don't say how many patients were analyzed with which of the machines. So this will be maybe a bit tricky. I don't know if we could do in time frames, because the machines are different kinds. But for CT, I think this is the most possible way, and we will make these subgroups. For MRI, we still need to check, because most of the machines were 1.5 Tesla, but then again, is it with MRCP, is it with diffusion? There are not that many studies that we were able to include, but we will need a way to stratify somehow.
But that's a very reasonable approach.
Thank you. Cu plăcere.
Yes, congratulations. I would like to ask you about the studies concerning imaging. Do these studies taken into consideration the size of the tumor? Yes. Because obviously most of the tumors are detected at an advanced stage. The real challenge is to detect cancers at a very early stage, which we are struggling with for many decades, even though the resolution of these imaging modules have improved quite a bit.
Yes, they say the sizes of the tumors, and it's from 2 to 4 centimeters in most of the cases. Of course, because pancreatic cancer shows symptoms in an advanced stage, there are not many studies with small tumors. Also, most of them are pancreatic head tumors, and that was also a bit expected. We will try to find patterns, but from what I could see until now, I don't know if we can somehow divide them based on that. But we'll look into it.
Thank you for your presentation. My question is about the first project where you have multiple follow-up times. Did you measure the change to baseline, the change to the follow-up time before, and what was the reasoning behind it? Or just the time at the time? Yes, we measured the means at that time. Mm-hmm. So not taking consideration what the baseline value was? Yes, we compared it. It was actually a complicated statistical decision because initially we wanted to do the network meta-analysis, but then we didn't have enough articles to perform a network meta-analysis. And the only way to work with this data that was very heterogeneously presented in the studies was to take arms, one arm from the studies and make a group, and then another arm and make another group. And we decided to work with these means because it was the clearest way to present the data. Okay, thank you.
Maybe one quick question, maybe my colleague already asked, was there any data in the studies about the resectability of the cancer? Because I know we are doing another study with my team as well, but borderline resectable, potentially resectable.
It was just unresectable, only unresectable. I mean, only also the PICO itself included the idea of unresectability, which now I feel a bit bad that we did, because maybe included more studies and more patients would have been nicer.
So there was studies about the other categories?
In the literature, yes, but we from start excluded them because we wanted to focus on palliative care and unresectability.
All right, thank you.